Mary Barbato, and welcome to Canary Health webinar, Do Digital Therapeutic Programs Work? How Better Choices, Better Health improves outcomes and reduces healthcare utilization and cost. We're about to start the webinar, but before we do, just a few housekeeping items. The webinar will be 30 minutes long with 15 minutes of Q&A at the end. All of our listeners will be on mute for the entire presentation. If you would like to ask our panelists questions, please enter them into the box on the right of your screen under Questions, and I'll receive them and ask the panelists your questions at the end. You'll be receiving a copy of slides from today's webinar and information regarding how to view the recording in the follow-up email next week. Please also take a moment to fill out our survey at the end of the webinar, which will appear on your screen when you exit. Now, I'd like to introduce our three panelists, Dr. Neal Kaufman, Chief Medical Officer, Canary Health, Dr. Kate Lorig, Emeritus Professor of Medicine, Stanford School of Medicine, and Juliet Simone, National Program and Health Director, Oasis Lifelong Adventure. Welcome, Dr. Kaufman, Dr. Lorig, and Juliet. With that, I'll turn it over to you, Dr. Kaufman.
So good morning, everyone. Really appreciate the opportunity to tell you about Better Choices, Better Health and the exciting results from a large study showing the impact clinically and economically on patients with type 2 diabetes who experience Better Choices, Better Health. For the 30-minute presentation, I'm going to start out talking about chronic diseases and why we are seeing an increase and why that's important. Dr. Lorig will introduce the concepts of self-management support. I know many of you on the line are quite engaged and expert in this, but it's great to hear from Dr. Lorig about that. She'll also present the highlights of the results from the Anthem type 2 diabetes study. We'll then hear from Juliet Simone describing her experience as an in-person provider at Oasis as part of the study and beyond. I'll then present the Better Choices, a Better Health program, so you have a better sense of what we're talking about, and then we'll take questions and answers. So first, I really want to start out with a story of one of our participants. It really describes in many ways what the program is about and what our mission really is. The individual says, I've had type 2 diabetes for 9.5 years. I've achieved a lot in my life, but before the program, I didn't feel like a winner. My inner self knew I wasn't doing that well. I wasn't guaranteeing myself longevity. What was critical about BCBH was the support. Support from the participants, support from the facilitators, and support from the materials. They see you follow through on your action plans and celebrate when you do. The material and facilitators, everything about the program was high quality. The program was fun and enjoyable because I learned something new each week. We receive these participant stories as part of satisfaction surveys we get, and they're the spontaneous description of their experience. I'll be reading a few others as the webinar progresses. I want to just briefly tell you about Canary Health. Again, many of you I've known personally and we've worked with and have been part of this experience. Others have not. We're a 3.5-year-old technology company. Our mission is to decrease the frequency and severity of chronic conditions. We do that by delivering digital therapeutics from outreach, meaning how do you outreach to someone, get them to sign up and show up, all the way to participating and succeeding. Digital therapeutics is a new term in the world describing a therapy that has evidence behind it, that is known to improve health, just like the therapies might be a medicine or surgery or some other treatment, but they're delivered digitally. They're delivered using technology, cell phone, and internet. We are unique in that in our digital therapeutics, we embed patient self-management support and the concepts that Dr. Lorig has championed into the services that we provide. And we've been fortunate enough to have engaged more than 65,000 people in our programs. And we think about the burden of chronic disease is really a major challenge. Most of you on this line are either directly or indirectly involved in population health approaches or in disease management approaches where you are responsible for a population who have or are at risk for chronic conditions. And we know that those chronic diseases are increasing in our culture, and they're persisting despite investments in healthcare, new medications, enhanced drug delivery systems, better monitoring devices. And certainly those have had a major impact on individuals' quality of life and on the rate of complications, but there still are significant problems. And we know that organizations accountable for population health who have chronic condition management still have a lot to do to really bring this to scale and to make a profound difference. We know that there are basically 4 elements of what is necessary to make this really an effective approach. Drive deeper patient engagement, deliver lasting outcomes that matter to the individual probably first, that matter to the purchaser, the payer, as well as the provider. And how do you do that? By decreasing unnecessary utilization and saving costs, because we know that is the nature of the world, and we obviously need to do that. And while you're doing that, the question becomes really, how do you improve the quality of care while you're improving the outcomes that matter? So again, another participant story. It is easy to feel like you're the only one facing a problem. To find out that 4 other people had the same thing going on was eye-opening. Just sharing experiences and ideas was worth the time. The book will be helpful for following up so I can continue to explore ideas and directions. In a culture in which we don't talk much to each other anymore, this was like a water cooler where you could visit with trusted friends, where you could have the opportunity to learn from peers. So I want to introduce Dr. Kate Lorig. I think to almost everyone in this audience, she needs no introduction. The guru is the major force behind the concept of self-management support. And I've asked her to really, for this webinar, present 2 main things. One is, what is self-management support? Why is it important? How does it fit into the continuum of supports and services that individuals with chronic illness need? And then to briefly go over some groundbreaking results from a large Anthem study that was done with Dr. Lorig and her colleagues and others. So, Kate, please tell us about self-management support. Why is it important? How do people benefit from it?
Okay. Good morning, all. Self-management support is simply what we as health professionals, as healthcare systems, as community agencies do to support people in their self-management. So then the question is, what is self-management? Self-management are the skills and confidence that one must have to do all the things for their chronic illness in the 99% of the time they're not within the healthcare system. And these fall really into 3 categories: self-management of their medical concerns. This is taking your medicine, doing your exercises. Self-management to continue doing the things you want and need to do, being mother, being grandfather, being worker, whatever. And finally, self-management of emotions. Because one of the things that we know about people with chronic illness is the large percentage of them are either clinically or subclinically depressed. And these negative emotions go along with chronic illness and are probably the largest barrier we have to good self-management. So if self-management programs and self-management support don't deal with these emotions, they probably aren't going to solve the problem.
So that's terrific. Should we go to the results of the study? You could tell us a little bit about the Anthem study?
Sure, why don't you move the slides there? Terrific. This was a very large study, 1,200 people, that was done with multiple partners. I won't even read them all because if I did, it would take the next hour. But as I say, a large study done over several years in conjunction with Anthem. For this study, people had to have type 2 diabetes. This was really real world. These were people that were covered by Anthem plans. They were largely recruited through the Anthem plans. Large sample, as I said. We used standardized questionnaires that are well known and well thought of. And the results that you'll see are really generalizable to most populations. Now, this study included both online, about 1,000 of those people, and small group. And so about 200 of the people were small group. We're going to show you the results combined because, quite frankly, whether people went to small group or online, the results were exactly the same. Next slide, please. You can see the enrollment numbers there. 16% of them were above 65 years old. Their mean age was 57. About 94% of them had private insurance, as you'd expect with an Anthem study, but 16% of them had Medicare. What we saw is at 12 months, we saw a decrease in hemoglobin A1C of 0.45%. We saw a decrease, a little bit larger decrease than that at 6 months for those that started out above 9. One of the things about this study is that because it was real world, we had a whole bunch of people in this study that had hemoglobin A1Cs of 6 and low 7s. And those tend to attenuate the results because those folks didn't move much at all. For those with hemoglobin A1C above 9 at baseline, we saw a decrease of 1.27 points at 12 months. So we're seeing large impacts on hemoglobin A1C, the key outcome in diabetes, over a long period of time. I talked a little bit about depression earlier. We saw a decreased, we saw a reduction in depression by about 27%. We saw improved medication adherence, increased exercise, decreased hypoglycemia, fatigue, poor sleep, and increased role function. That's what illness intrusiveness is. It has to do with that second part of self-management of role function. So basically, we got the outcomes that we were looking for, and these outcomes all persisted for 12 months. Next slide, please. There was a secondary study done on costs. This was done by Anthem. Anthem was able to find out of our sample 558 patients that had data both for the year before the study and a year after the study. They matched these 3 to 1, and using a propensity score, they matched on age, gender, utilization, comorbidities, and probably about 12 other variables as I remember it. And from this cost study, the bottom line was that reduced 12-month all-cause utilization costs, reduction in pharmacy, emergency department, inpatient and outpatient services, reduction in 12-month total healthcare costs of $815 per person. And the bottom line of this whole study was that Better Choices, Better Health returned a 3 to 1 on investment. Next slide. This kind of says the same thing again, but in a little bit different way. Reduction in all-cause healthcare utilization costs, reduced burden of comorbidities, decreased claims for hypertension, hyperlipidemia, depression, renal disease, musculoskeletal diseases, rheumatoid arthritis and osteoarthritis, decreased healthcare utilization for comorbid conditions. Interestingly enough, there was minimal change for diabetes-related costs. And this actually probably isn't too surprising because one of the things that we were doing is we were urging people to get their tests, and their testing all did increase, which would have increased their charges for diabetes-related care. But just the same, we saw this reduction. And again, the total cost savings attributed to the intervention were $815 per person.
So, Dr. Lorig, thank you so much. We'll have time for questions after we present. I wanted to bring Juliet Simone into the conversation. Juliet will introduce herself, but she is a part of Oasis Lifelong Adventure that is involved in that has 9 different cities with their services, and was the provider of the in-person version of the CDS-MP, the Chronic Disease Self-Management Program, to 232 of the study subjects. So Juliet, please introduce yourself and then tell us about Oasis and why it was involved with the study, and anything else you think the audience would like to hear about your approach to in-person chronic disease self-management.
Sure, thank you, Neal. Hello, everybody. My name is Juliet Simone, and I have a public health and business background, and I am the National Health and Program Director at the Oasis Institute based in St. Louis, Missouri. But as Neal mentioned, we have 8 other cities in addition to St. Louis from coast to coast. And we're a nonprofit that's been around since the early 1980s with a 3-pronged mission, which is to provide lifelong learning opportunities, ways to get engaged in the community, and ways to stay healthy as people age. And the main focus of our organization is having opportunities for older adults to get together for those reasons, whether it's a hiking and biking group, whether it's the chronic disease self-management program, or a history talk on, the letters of John and Abigail Adams. We try to run the gamut on those sorts of programs. And we were involved in this research study back when it was starting in about 2012 to deliver the in-person workshops in St. Louis and Indianapolis. And so we had been providing other evidence-based programs for several years before this, but this opportunity really helped us kind of ramp up our ability to bring these programs to capacity across at least those 2 cities. And so a few staff people in both Indianapolis and St. Louis, including myself, were master trained in these programs so that we could train the trainers and increase capacity whenever we really needed to. And we do a peer model for these programs. So we recruit and train older adult peer facilitators to then go back and teach folks in the community. So that really helps us at Oasis achieve 2 parts of our mission, which is to engage older adults in meaningful volunteer opportunities, and then of course to directly deliver these disease management programs. So we got involved with this study because it meets 2 parts of our mission at least, and we had already been providers of other evidence-based programs. So it seemed like a really natural fit for us to be involved. And we jump at the opportunity whenever we can to be part of any kind of research project that will provide meaningful results on a national scale. And the workshops definitely made a difference in the lives of the older adults directly that were participating in these workshops, but also of the lay facilitators that were leading them out into the community. So, I heard from many of the facilitators that, when they taught these workshops themselves, they always did a little bit better on their health behaviors as well, because it does kind of kick you into gear when you have the accountability of these small groups, as Kate mentioned earlier. So it does really make a positive and meaningful and lasting impact. We've also had groups after the 6 weeks have ended that continue to assemble because they really just enjoyed each other's company and support and the power of being around a group of people for a similar reason. And that has been definitely a sustained benefit of being a provider of these programs over the years. And we do really think that the research results from this study is quite compelling. And as there's a national movement for nonprofits and aging service providers like Oasis to gain more business acumen skills and really look to the financial benefactors of these programs to become investors in the programs, these results align perfectly with, better patient outcomes, better health, better patient outcomes, better patient experience, and as Kate mentioned, also reduced costs. So we really hope that this is just a piece of the puzzle, be it significant, to make that compelling case for direct program implementers like Oasis to be sort of sustainably funded and to increase capacity to help meet the need.
Juliet, thank you so much. We'll again have time for questions from Juliet. If you want to please put questions into the chat, Mary will compile them, and then we'll get them in about 10 minutes. So I'm going to now enter the third part of the webinar and talk about Better Choices of Better Health. So participant story that tells a lot about the program. BCBH is a total program. It includes reading, discussing, questioning, and above all, establishing goals and objectives in a systematic methodology. You make better choices for yourself. You interact with other people, some who have far more difficult circumstances than you do. It inspires you to share with them and to act yourself to improve your health. I've lost 45 pounds. All 20 of my recent lab tests were normal. My diabetes and arthritis are under good control or in remission. Life can be so good. So let me give you some of the history of the creation of the self-management support program. Dr. Lorig, over 3 decades ago, originally developed CDSMP at Stanford, the chronic disease self-management program. It was based on the foundational research that she and others had done, documenting the critical role of self-management support. It's been the gold standard for this kind of an approach, with worldwide deployment in over 30 countries, in 17 different languages, with over 1 million participants. Hundreds of papers have been written describing how this improves outcomes for individuals with a variety of conditions: arthritis, diabetes, depression, multiple chronic conditions, etc. And what's important and been exciting in our partnership with Dr. Lorig is that as she created the digital version 10 years ago, and as we became involved about 3.5 years ago, we continue to evolve the program, both the in-person and the digital, based on relevant national standards as things change in the diabetes or chronic disease world, with new information that comes out, what we learn from the various studies that have been performed, and technological innovations. And the biggest technological innovation was the transformation of the chronic disease self-management program, which was in person to a digital format. So what is it? It's a 6-week peer-to-peer, group-based, interactive, educational, story sharing, and self-management support workshop. Individuals come together, and I'll explain that in the next couple of slides, to really share with each other their life experiences, to learn how to manage their lives, their relationships, their emotions, and their medical care. And core to the approach, as Dr. Lorig mentioned, is improving self-efficacy, the capacity and confidence to set and accomplish the goals that matter to you. And individuals in the in-person or in the digital program are able to self-tailor the kinds of experience they have and what they get out of the program to meet their needs. And if you think about who can benefit from these kinds of programs, diabetes is the poster child for it. It's the poster child for self-management because of the multiple activities every single day the person needs to do. But if you look at the ones surrounding this oval, it's been shown to be effective in asthma, COPD, heart disease, arthritis, depression, hypertension, hyperlipidemia, almost any chronic condition. If an individual has one or more chronic conditions that require daily self-management, that's really the key. And the individuals are making scores, hundreds of decisions every day, not one of which may be critically important, but the sum of which determine the outcome. And their attitude and their feeling of confidence make such a difference as to whether they're able to implement, understand, implement, and sustain those healthy behaviors. The workshops are very similar, in person or digital, the same protocol, same curriculum. Basically, there's 5 elements that are covered in almost every weekly educational session, delivered in person by the peer facilitator, delivered online, someone reads it. It focuses on self-management principles, action planning and goal setting, pain management, relaxation, and problem solving. And then there are additional content subjects that are introduced each week, a little bit each week, and maybe 2 or 3 of them might be covered each week. They may be covered more than once. That look at the lists that are there, some of the activities around handling difficult emotions, increasing physical activity, eating better, sleeping better, reframing pain so that you can understand how to manage it better, communicating with family, friends, coworkers, and healthcare system and the like. And the program is 6 weeks long. It starts in a digital version every Monday. We have at least one, if not 2 or 3 workshops begin. Anywhere from 20 to 25 people come online and join that group. In person, it's usually 10 to 15 people. The fundamental difference between the in-person and digital is in-person is obviously synchronized. Everybody's in the room at the same time, 2.5 hours a week for 6 weeks, the 10 to 15 participants, the 2 peer facilitators. Digitally, it's asynchronous. What that means is you don't come on at the same time and communicate in the moment with the other members. You come on each week, you have a guided lesson, as I mentioned, that the content for that week. You do a certain amount of action planning, trying to think about what is a behavior that you'd like to work on. It could be anything you care about. It doesn't even have to be a healthcare or health-related item. It's whatever you want to work on. And you're helped by your peers who respond to that action plan posting to think about suggestions or how you might accomplish that goal. There's then discussions in person, online. A person posts a comment or a question. It may be, I know my husband loves me, but he nags me all the time about my diet. Any suggestions on how I can get him off my back? So it's not as much about what the diet should be, though that certainly sometimes comes up. It's really about the emotions, the relationships, the roles, the changes. Someone may say, I've never told anybody at work I have diabetes. I'm afraid someone will treat me differently. Any suggestions? That's a great conversation piece for peers to help peers moderated by the facilitator. So they get that support, and then that happens again. So next Monday, second week happens. Following Monday, the third week happens, etc. And the program is being used in a number of ways. It's a standalone element of a disease management program where an organization specifically has a comprehensive disease management program, and the BCBH is offered as a complementary service to it. It may be part of a well-being initiative that employers have, where they're specifically looking at individuals with chronic illness and helping them to improve their well-being. It could be part of clinical care, where, for example, Kaiser in Washington offers both in-person and digital as part of their ongoing routine care for people with chronic illness. So it's a combined opportunity, a dual venue, if you want to think of it that way, where people can answer it either way, or could participate in more than one way. It may be integrated into an element for chronic condition or population health program, again, thinking about a particular subpopulation. It may be integrated with a digital therapeutic, again, that concept of a therapy that's provided digitally. That's a way to think about our virtual DPP program, which is fully recognized by the CDC, is infused with some of these self-management principles. And stay tuned, I can't announce it yet, but you can embed it within a partner's condition management service. Think of it as somewhat part of the service that has healthcare professionals helping someone actually manage the details of their disease. And diabetes, you can imagine helping manage glucose and complications, side effects, et cetera, and linking it into an experience around self-management support. So my final story, Better Choices gives you literally hundreds of ideas and doesn't ask you to do them all, but pick a couple that you want to do. In combination with the support you get from the group, it worked. Before the program, I was on a bunch of medicines. I'm on 1/3 of those medications now. Better Choices, Better Health has been more valuable to my health, mental health, and well-being than any other thing I've tried in years. Now, these are unsolicited stories that people have told us, and we're very interested in understanding people's stories, understanding how to help someone get the health they need for the life they want. And often our participants will describe how they're much more likely to be able to set those priorities and to live on them. But as it says, there's hundreds of ideas, but you only have to pick the 1 or 2 or 3 that make sense for you. So in conclusion, I hope we've demonstrated that Better Choices, Better Health, both in person and the chronic disease self-management program, digitally, and the chronic disease self-management program in person improves clinical and economic outcomes, that self-management support is really key, foundational to a complete solution that's going to have long-term sustainable changes in people's medical and economic outcomes by changing and helping them manage their lives, relationship, emotions, and disease. That digital therapeutic approaches can augment in-person services and supports be they disease management, be they a much more detailed clinical approach, that using evidence-based approaches is really critical. That when digital therapeutics are based on evidence of what works, often in person, and then transformed into a digital program, that's our key approach, that it makes a huge difference. And the part that really I think is different than many people think when they have a subspecialty way of thinking is that pay attention to comorbidities. If you do that, you're much more likely to demonstrate improved health outcomes and lowered cost than if you only focus on in this case, from this research, diabetes. So we're interested in partnering with anyone who wants to work on ways to improve their population and condition health management services, and we'd be happy to not only take questions now, but also if people have other information, they can certainly contact me. So Mary, any questions that we have heard? Let's get started on the Q&A.
Great. Thank you, Kate, Juliet, and Neal. We've had a lot of great questions come in and some really unique ones from our listeners today. If you'd still like to send in a question, kindly add it to the question sections in the box to the right of your screen. So one of the first questions that came in, and Neal, I'm going to pose this to you, is does the program come in different languages? And specifically, they're asking about Finnish.
At this time, it is not in any language other than English. We actually have Spanish and French on our roadmap. French because we have purchasers, partners in Canada, but at this point it does not.
Neal, the small group program is available in Finnish.
Yeah, I think that's a great addition, Kate. The small group in-person program is often the way that in a dual venue approach, they can not only offer it in Spanish or other common languages. Many people have trained facilitators who come from other cultures and languages and are able to provide that service specifically for a range of different languages. The materials have been translated, though.
Yeah, the materials have been translated to Finnish. In fact, it's a national program in Finland. The small group program is.
Great. Thank you both. The next question I'm going to pose to Juliet first, and then Neal, if you can add on to her comments. It is, how do you reach out to prospective participants?
Sure. So it really depends on a number of things, of course, one of them being budget, and others being on what kind of venue the in-person is being delivered in. So for the study, we used a lot of direct mail. It still worked for a lot of our older adult participants, and we saw, I guess like the sort of average response rate, which is between like 1% and 4%, I believe. However, we also, as a team, do a lot of grassroots effort for participant recruitment. So if it's at a church, we'll talk to the older adult group. If it's at a library, we make sure that it's cross-promoted. But we work with any partner in the community that you can think of, including community hospitals, libraries, other faith-based community locations, community centers, local municipalities, you name it. We've done it all, and we're open to doing it all.
So I think this is actually one of the most important questions and challenges in doing any program, evidence-based program, in person or digitally. And we think of it as interventions begin at outreach, and they end when the individual succeeds or may unfortunately drop out. And if you think about outreach to get someone to know that the program exists, activating them so that they'll recognize that maybe they're at risk or maybe they should enroll in the program, signing up for the program, and then showing up for the program. And all four of those steps are critical. You lose people along the way when you do that, so to speak. And the goal is to keep as many people in that enrollment funnel from outreach to activation to sign up to show up so that they then can participate and succeed. We do that in a number of ways. What we've learned over the years is if you don't focus on that with your partner, with the purchaser, with the health plan provider, employer benefit board, that you're not going to be successful. So identifying upfront who's eligible, segmenting the population that might be possibly eligible into those that the purchaser prefers, using a population health approach to identify those individuals, and then to craft in the voice and logo of the purchaser, of the host, a messaging campaign. And that differs really depending on the organization. In some cases, the organization has a well-run machine communicating with its target audience effectively, whether through a patient portal or through newsletters and other digital formats. We then give them advice, suggestions, and they do it as they know best. In other cases, it's been the exact opposite, where an organization has said to us, we want you to do the whole thing. So on their behalf, with their brand and not ours, with approval from the host organization, from the purchaser, the payer for the service, we craft a digital campaign. And typically it's a campaign that provides messaging to the individual multiple times over time. It's called a drip campaign, where we're basically analyzing what messages resonate with what kind of people in the best of ways. The future of artificial intelligence and big data is to be even better at targeting and messaging in ways that individuals are more likely to respond. So it's a digital outreach, typically for a digital program, that seems to work better. The individual at least has to be able to receive an email to be able to participate in our program, and then they log on to a landing page with the branded name of the host organization to learn about the program, to listen to other people who have been part of the program, participants, to ask questions or to see answers to their concerns, and then to sign up for the program.
Thank you. And Neal, I've got a question that came in for clarity from the audience. Is the Anthem research for the online diabetes program, or for Better Choices, Better Health, or for both? Can you clarify that?
Better Choices, Better Health, Diabetes.
Thank you. And this next question is for Dr. Lorig. How do you explain the persistence of new healthy behaviors from such a short intervention?
Because we actually emphasize that the behaviors are done because the person wants to do them. And we teach the core skills of action planning, problem solving, and decision making. And therefore, what we're really trying to do is help the individual so that when a new problem comes up, they will have the skills to deal with it. There's a large belief that you have to keep reinforcing things. But in fact, what we found is that if you give people the skills and the confidence that that's not necessary, our 1-year results tend to be better than our 6-month results. And we've seen results up for as long as 4 years, which is our longest study. So I think it's because of what we teach. People are doing this not because we're telling them to, but because they're making the decisions to do it, because it's self-tailored. Self-tailored means that they make their choices, and therefore they're more likely to keep on doing them. And just to give you an example of that, my guess is that nobody in the audience has been told how to brush their teeth for many, many, many years. And in fact, we brush our teeth every day because it's a self-reinforcing behavior. And that's what we try to establish in our programs.
Thank you. This next question is for Neal. What % of participants complete the workshop?
So that percentage varies in person and digitally. It's anywhere from 60 to 70%. Dr. Lorig has studied what a completer means and found that if you participated in 4, 5, or 6 sessions, that your outcomes were very similar. So a completer is defined as someone who has participated in 4 out of 6, and it's anywhere from 60 to 70%.
Thank you. Another question that came in, and this can go to Neal or Dr. Lorig. How and when are coaches utilized?
Let me start answering that. So coaches, in our case, we call them facilitators. They're peers. In the in-person version, they are the organizers, and they attend each of the workshops, provide the content, and then facilitate the conversations around action planning and around discussions and celebrations and other aspects. Our facilitators in the virtual version, the digital version, actually do the same, but they do it in obviously a different way. Their role is, one, to model what behaviors and language would be to try to show people the way that they might give support. Two is to respond to any posting that is not responded to by a participant within 24 hours, so that the person posting it at least gets a response from a facilitator who is a peer. The third is to look for any kind of safety or harm. The person might have suicidal ideation or something else that is very worrisome, to make sure that the participants are not inappropriate. Oh, of course you should stop your insulin. I stopped mine. Obviously that's not appropriate. And those facilitators, whether in person or digitally, digital facilitators, have been trained by Dr. Lorig and her team to be facilitators in person, and then we give them special training for the digital.
Thank you. And Neal, this next question is for you. How is the program paid for, and how much does it cost per person?
The program is paid for currently by what we use the term a purchaser, someone, an organization that for one of many reasons wants their patients, their members of a health plan, or their employees to improve their outcomes for their chronic condition. We make a contract with that organization who then determines who is eligible, how the recruitment's going to happen, and pays for it so that it's free to the individual. In the in-person version, there are sometimes contracts with plans or providers, and often federal grants or other local foundational grants or others that are helping to pay for it as part of their community-based nonprofit organization. The cost, I can give you approximate numbers. It really depends on the number of participants. And I won't speak to the in-person cost because that's not my side of the equation. And I don't know if Juliet would know for others. But we have two different ways that organizations can pay us. In the past, we always had a fixed fee where for a person to sign up or show up, we would get paid a certain amount. Increasingly, we offered over years ago and recently been accepted to be paid for performance and to be at risk. So in either case, if you want to think about just a ballpark number, we get paid about $275 per person that shows up to the program. The other method is we can get paid in two equal payments of about $185 per person for someone who shows up, and another $185 for someone who completes. So that puts us at risk, if you want to think of it that way, or pay for performance for that outcome of completing the intervention. Larger numbers and going to scale can have very different approaches. We're interested also in figuring out with partners how to have that payment come from claims rather than from administrative dollars. We've done that with a couple of our health plans who we submit a bill to as if we were any other kind of provider and get paid by claims. That helps that money, that fee, to be on the clinical side of the medical loss ratio rather than on the administrative side.
Thank you, Neal. This next question is for Dr. Lorig. Why are peers used to facilitate the workshops and not professionals?
Peers are used because by being a peer, they have a chronic disease. They're like the people that they're working with. And therefore, they're believable models. They've been there, they've done that. That's the primary reason that we use peers. Because behavior change, one of the key behavior change is seeing somebody like yourself succeed. And that's what peers are able to do. Also, because our programs are so very, very large, to find enough professionals to do that and to do it well would be very, very difficult and very, very expensive. In the past, we've done studies where we've looked at, was peer facilitation better or worse or the same than professional facilitation? What we found is that groups facilitated by professionals ended up knowing more. Groups facilitated by peers ended up with more behavior change.
Thank you. And Dr. Lorig, what type of training do the peers go through?
The initial training is 4 days. During those 4 days, They see every activity in the program. They actually participate in the activities. They also do practice teaching, and they learn a bit about why things happen the way they are, how to deal with difficult people. Then, if they're going to be facilitators online, people that have already been trained in the small group format take additional online training to understand how do you model in your posts to other to participants, what do you do about safety concerns, things of this sort. And that training is several weeks. People actually take the online program, and then they are mentored as they first start facilitating that program. So it's a fairly long, complicated process. One of the things that's kind of been wonderful is it seems like there's a whole lot of people that want to do it.
Great. Okay, and this next question is for Juliet, and then Neal, if you want to add in. How well does the program perform with older patients?
So our primary audience at Oasis is older adults, and so we see participation and improvements and program satisfaction to be really high among the participants or among older adult participants. So, and the research showed, the same sorts of outcomes for different age brackets.
Let me respond to that from the digital perspective. Years ago, we had lots of people telling us that people over 50 or over 60 or over 70 wouldn't do a digital therapeutic, wouldn't do a digital intervention, and that's just not true. Obviously, there are some people who choose not to use digital, and that may be independent of age. They may prefer an in-person group where they're interacting with live other people, and others may really prefer to never go to an in-person group, but would rather be in a digital version. So as was mentioned, the results in the Anthem study and others have shown no difference if you're over 65 or under 65. The average age across the study, as well as across our own series of participants in the digital version, is 57, 58 average, going up to 75, 80 or older. And so I think we recognize that older adults have accumulation of one or more chronic conditions much more frequently than young adults. So we do have people under 30 or 40, but most of them are 50, 60, 70 or older and really do well.
Great. And Neal, we have time for one last question. Do you have time for one more?
Sure.
Okay. Can I integrate BCBH with my current care offering?
The answer is definitely. It requires some thinking. It depends on what your care offering is. If you're talking about a telephonic disease management support service where a coach who might be a healthcare professional is helping that individual better understand their chronic condition, their medication therapy, whether it's with COPD, asthma, whether it's with diabetes or some other condition, having Better Choices, Better Health be foundational to help that individual, as Dr. Lorig said, be ready and able and willing to understand what needs to be done. I would use the words, be better prepared to follow the medical regimen. It certainly can be integrated. And we're very interested in finding organizations. We're always part of someone else's ecosystem. It's never our own product. It's always under someone else's brand and label and approach. So all of them have been in one way or another integrated into a care system.
Great. We do have more questions. Should I continue and stay on the line?
I think what we should do is we'll take those additional questions. We know who has put it in, and we'll be able to send answers to that. Also, after this webinar is over next week, you'll receive a copy of the webinar slides, a way to have your colleagues link into and watch the program. We'll also send you some information, for example, how to log on to a 3.5-minute demonstration of the program. So I think we're a little bit over the 9:45 time in Los Angeles, and so I'd like to suggest that we officially close the webinar at this time. And thank you all very much for your participation. I do have some slides, which if people want to stay on, I will go through them. They're basically screenshots of the Better Choices, Better Health program. Don't feel obligated to stay on and listen and hear about that. We'll include them in the slides that the slide deck that we send out to you. It also will have the way to see an actual demonstration of it. So thank everyone. Appreciate your participation. Please, whenever you do leave the webinar, complete the survey. It's very, very helpful for us to learn how to do these better, because I know we all can improve in the way that we transmit the information. So thank you all for that. So I'm going to continue and describe the Better Choices, Better Health user experience. In the slides, you'll see that there's a link to a demo site that you can go to where you'll be able to see a 3.5-minute demo that was done at Health 2.0 last year. There's also one of what are many user experience slides where an individual talks about her diabetes and what that happened. So if you think about someone has been heard about the program, has logged on to our website, decided that they wanted to enroll, is already covered by their purchaser, their host organization. They log on and pick a workshop date. They usually can have one within a week, 2 weeks, or 3 weeks. They always begin on Monday, and the individual chooses the best date for them, does that, and then they're given a self-test. That occurs before the workshop begins. It's designed to give people insight into what are the key issues that are important to them. They take that self-test while they're waiting for their workshop to begin. They also can watch videos of other people who have gone through the program. They can have other questions answered, and they're getting ready for that workshop to begin. The self-test results are provided to the participant in the midst of the workshop and used as a guide by that participant to see what elements they may want to self-tailor, because maybe fatigue is a big issue for one person and pain might be a big issue for another, for example. They're now sitting on the home page where the individual is able to begin the program. They're able to look at the sessions. They're able to tunnel into the key tasks that are necessary for them. And they are able to have a deeper dive into some elements over another. It is mobile friendly, though I would say most older adults probably do it on a laptop or on an iPad. You can do it on your cell phone. Personally, I'm 69 years old. I do a lot on my cell phone, but I don't like reading long things that way. So people often will vote with their clicks and use it in a PC approach. There's interactive learning. As I mentioned, there's those lessons that are given every week. Takes a person about 15 to 20 minutes. The content is provided gradually over time, given those topics that I mentioned earlier. The person can go back and read about that topic in more detail. They can read about it again. It also references Dr. Lorig's book, which is a bestseller that describes in even greater detail many of the things that are covered in the lesson. Some people swear by the book. They read every chapter. They love it. Others look at it more as a reference text, but it's certainly been a great adjunct to the workshop, whether in person or digitally. Individuals make an action plan. So this is a methodology that Dr. Lorig has refined that looks at how do you help someone to identify a behavior they want to do, that they feel that they can accomplish, but not be so confident that they know they can. So, you want to help the person to pick something that's a little bit of a stretch, but not something that is so hard that they'll never do it. They're not going to run a 10K or even a mile if they can't walk to the mailbox. So you have to come up with something that help the person to come up with something that is reasonable and appropriate. It doesn't have to even be healthcare related. Dr. Lorig tells the story of a woman who said she wanted to learn 3 words in her native Alaskan tongue. And the reason was so that she could better communicate with her grandmother, that she felt disassociated from her. And that's nothing to do with health in the typical sense, but it really had to do in the relationship, but also in the woman's ability to feel like she'd accomplished something. So whatever those issues are, most people that start out with non-medical or non-health related issues, by the end of the time have picked them up, but they don't have to. They can pick and work on whatever they choose. The discussion center is where the conversations occur. So thanks, talking to loved ones about my health. I'm frustrated, monitoring blood pressure, or the headlines that Muriel Barb and Ms. Missy have said. There are no pictures. There's only avatars on the program, so people can identify who it is that's doing it, but it's completely anonymous. And that person posts a question, a concern, an idea, a suggestion, whatever it might be, goes away, comes back in a day or two, and they see that other people have commented on it. So they make a comment, the person reads that comment, responds back if they feel that it would be helpful, facilitator enters into it, and they're telling stories. They're telling their story of their own life in a sort of bite-sized piece of an issue. Someone may say, well, I did this and it helped me in my relationship with my daughter or son or whatever it might be. And again, the facilitators are there to monitor the discussion, to make sure that it's appropriate, to make sure there's no safety or harm related concepts or comments that have been made, and then to provide support by role modeling how to best support your colleague, your peer. The celebration board, where the individual can post whatever it is that they want to celebrate. The group looks at it, they understand it, it reinforces success and behavior change. People start out often with one kind of celebration at the beginning that are kind of generic, and then often change to be much more behavior and health related as they go on. There is an alumni community. It is not a core part of the 6-week peer-to-peer self-management support program, but a number of participants over the years have asked for that, and so we have a digital alumni community. In that case, individuals who have finished the program, who have learned how to do this peer-to-peer support and how to identify questions and concerns and provide and receive support, enter into an alumni community. That alumni community does not have content in the way that the original program did. It's much less intensive. People come on an average of once a week or maybe even every other week for 20, 30 minutes to see what people have said, to read new content, to read new postings, to give their comments, and then to come back in a little bit to get it re-energized. Some people use it very frequently. Others use it much less frequently. But we find that it is a nice add-on. People stay on anywhere from 3 months to 6 months. They can stay on for a year or longer. We don't really ever kick anybody off. And there are hundreds of people, sometimes thousands in the alumni community. So I hope you got a sense of the program from this presentation. I'm going to go back to that first slide. Keep it up for a little bit if you want to write it down. https://goo.gl/AV6R5G, a nice easy one to read, can give you a live demo of the program. If people are on the line, they can ask a question if they have any. Mary, if you're still there, if you see anybody asking a question, I'll also look to see if there are any questions from this.
And Neal, I'm still here too.
Are there any questions that people have, Mary, that have?
Yes. Yes, there's one that came in. It says, in terms of the cost savings, was that $819 per person for all patients enrolled? In other words,
I'll answer the question. So the sample size that had all of the economic data was too small to do a sub-analysis of those who were high cost or high A1C. So it was representative of the entire sample, similar to the whole sample in terms of entry level, A1C and cost. And so that $815 was across the entire population. We're going to see if there's a way to do a valid study with just those that were high cost or those who had a high A1C, but I'm not optimistic that that will be technically feasible.
Okay. Here's another question for you, Dr. Lorig. What do you think about offering participants the choice of in-person community-based CDSMP or digital BCBH?
I think offering choice is the way to go, because people that like online will never go to small group, and many of the people that are going to small group face-to-face will never go online. So to get the biggest bang for the buck, you want to offer both. And the few places that we have seen that have done that have really upped their participation rates. So that's the ideal.
I agree.
And Neal, one last question before the hour. Oops, I'm sorry. Go ahead, Kate.
I was going to say, it's not either or, it's both and.
Thank you. And then one last question before we end, Neal. What do you see as your biggest point of difference or strength versus traditional disease management programs for people with chronic diseases?
Yeah, I think the brilliance of Dr. Lorig's approach that helps individuals be ready to follow the medical regimen, to be able to follow the doctors and nurses' orders, is what differentiates programs that use self-management support as a core element, in our case, either as standalone or embedded within a broader healthcare delivery ecosystem. People, if it's an acute illness where the doctor controls everything because you're in the hospital unconscious, self-management support is not critical, obviously. But for any program, and Dr. Lorig talked about the 99% of the time you're not in the doctor's office, more importantly, the decisions that you make have such a profound impact on your health, your trajectory, your future life, your death. All of those things are done by the individual, who is then activated, engaged, less depressed, more likely to be able to manage their emotions, relationships, roles, and their chronic condition. That differentiates us from organizations that are doing good work but are focusing on the disease elements. Think of diabetes and glucose management, high blood pressure management, etc., rather than augmenting it with the self-management support infused theory, practice, and in our case, evidence-based.
Thank you. So we've come to the end of the hour. Thank you, Neal and Dr. Lorig and Juliet, for your time today, and thank you to our listeners. Please complete the survey, which you will see in a few moments. Have a nice day.
Thanks, everyone.